All right, welcome everyone. My name is Ilana Kiefer and I am the Program Officer at the Center for Healthy Aging here at the New York Academy of Medicine. I'm delighted to welcome you to this afternoon's special event called A Dialogue about New York's Medical Aid in Dying Act. This event is sponsored by NIAM's sections on nursing and healthy aging, as well as by End of Life Choices New York. I want to say a quick word about the vision for NIAM. As some of you may know, the New York Academy of Medicine has improved communities' health by driving systems change for over 170 years. Grounded in a vision that everyone should have the opportunity to live a healthy life, NIAM generates knowledge to inform policy and programs, works collaboratively with local partners on community-driven solutions, and engages the public to achieve its mission, which is to drive progress towards health equity. In addition to our 2,000 fellows and members who are preeminent experts in health-related fields, NIAM has several grant and fellowship programs to support the pipeline of early career professionals in health and medicine. We are also working with other young professionals to raise the visibility of the social factors that influence health and health outcomes. Today's program will be moderated by Ayana Woods, who is the Executive Director for End of Life Choices New York. Similar to NIAM's mission, Ayana is passionate about addressing health disparities, and she has spent the last 20 years developing health education and outreach programs to promote wellness, successful management of chronic illness, and patient empowerment. It is now my pleasure to turn the Zoom podium over to Ayana.
Thank you, Elena. Good afternoon to everyone today. I just wanted to give a little information about End of Life Choices New York. We're the leading nonprofit in New York State, providing support, education, and advocacy to ensure that New Yorkers' wishes and values are respected at the end of life. And we are so pleased and honored today to be working on this program with the New York Academy of Medicine. We think this is going to be a great discussion today, and we're really excited to be a part of it. We have a fantastic panel of experts with a variety of perspectives on this topic, which should lead to a lively conversation. We have 5 panelists today, as I mentioned. Each will speak, just to give you an agenda for the day, each will speak for about 10 minutes. And then we'll open up to discussion. So as you hear a panelist maybe say something you want more clarification on, please type up your question into the chat. And once we're all done, I will be facilitating and moderating and asking those questions. So if you have a question that's directed to a specific person, please note that. Please note their name and then your question. If it's a general question, you can just write it in the chat. You probably received the amazing bios of all our attendees today, so I'm not going to take time to go through all of those, but I just wanted to give you a sense of what people will be discussing today. So we're going to start our program with David Leven, who will provide an overview and history of medical aid in dying, followed by Assemblymember Reyes, who will talk about the Medical Aid in Dying Act in New York. And then Dr. Muller will talk about why medical aid in dying should be an end-of-life option, followed by Dr. Dugdale, who will talk about why medical aid in dying should not be an end-of-life option. And then we'll close with Mary Ellen Trisgallo talking about a nursing perspective on the issue. So with no further ado, I would love to turn it over to David Leven.
Thank you very much, Ayana. I'm very pleased to be here this afternoon and look forward to our discussion. So this is an issue, medical aid in dying, which I have been studying for the past 18 years. And just by way of further background, I have been a public interest lawyer throughout my career, advocating for people, seeking justice for poor people as a legal services lawyer for the poor for 10 years in Rochester, as the executive director of Prisoners Legal Services in New York for 20 years, seeking justice for prisoners. And now for the past 18 years, working with End of Life Choices New York, seeking health justice for patients. And I believe that medical aid in dying is a health justice issue. I hate human suffering, as we all do, and really hate unnecessary human suffering. So life is precious, but it's really going to end for all of us. And the only question really is how it's going to end. Patients with decision-making capacity may now control the timing and manner of their deaths. They can stop or never start life-sustaining treatments, mechanical ventilation, dialysis, pacemaker, antibiotics, feeding tube. They can also voluntarily stop eating and drinking if their suffering becomes too great for them. And this is legal throughout the country. Another way in which hastens death is palliative sedation, even though most people who are palliative sedated are going to die in any event within a very short period of time, within weeks. And of course, we know that healthcare agents can make decisions, and they do all the time, which hasten the deaths of patients by not having life-sustaining treatment started or by stopping them once they're started. But think about this. None of these options that hasten death generally have mandated statutory requirements or safeguards. And I want you to consider this as we now discuss the end-of-life care option of medical aid in dying. Medical aid in dying is a very simplistic concept. It occurs when a terminally ill, mentally competent adult patient who is likely to die within 6 months takes prescribed medications which must be self-administered by the patient to end suffering and achieve a peaceful death. From everything I have read about medical aid in dying over 18 years, I am absolutely convinced that it should be an available end-of-life care option, in addition to stopping or never starting treatment, voluntarily stopping eating and drinking, and palliative sedation. Medical aid in dying now occurs across the country, but except where it is now authorized, it is done underground, it's unregulated, and it's probably illegal. The practice should be, in my view, legal and reasonably regulated. Physicians and family members should not be at risk of punishment as they are now. Now there are 11 jurisdictions across the country which permit medical aid in dying, including our neighboring states of Vermont and New Jersey. And we now have 70 years of cumulative experience with medical aid in dying across the country, where about 1/5, 1 out of every 5 people who are dying have access to medical aid in dying. Medical aid in dying has been considered to be assisted suicide historically, but that has been changing rapidly over a number of years. And it's not assisted suicide according to the laws enacted to permit the practice in those states which allow medical aid in dying. And consider that there are really stark differences between a typical suicide and medical aid in dying. Suicides are committed by those who, usually with a mental health issue, can continue to live but choose not to, are done in isolation, often impulsively and violently, and they are tragic. To the contrary, medical aid in dying is only available to terminally ill patients who will soon die. They don't usually want to die, but a disease is killing them and they're going to die. It occurs only after consultation with at least 2 physicians and almost always with family support, with the vast majority of patients receiving hospice care. It usually takes several weeks from the first request until drugs are taken, if at all, and it is empowering. And with regard to the drugs that are being taken, about 1/3 of patients who get the drugs never even use them. And contrary to the thinking and the fears, understandable at the time, of opponents and skeptics who thought that this was going to be an option that was going to be used greatly, it's in fact rarely used. Only about 1 in 250 people, 4 out of 1,000, actually end their lives by medical aid in dying. But it gives great comfort to those people who are dying and who may be suffering, and peace of mind to those people to know that this option is available to them if their suffering becomes unbearable. The term assisted suicide is rejected by numerous organizations: the American Public Health Association, American Academy of Hospice and Palliative Medicine, the American Medical Women's Association, the American Academy of Family Physicians, among others, and as I mentioned, all of the state laws which permit medical aid in dying. In 2017, the American Association of Suicidology, an organization which is designed to prevent suicides, issued a statement. The statement entitled, "Suicide is not the same as physician aid in dying." And it raised 15 points of distinction between suicide and what they call physician aid in dying. The laws allowing medical aid in dying have worked as intended, according to numerous studies. There's evidence that deaths by medical aid in dying are at least as good, and in some cases better, than other deaths, and they occur much more quickly, generally speaking. There is evidence that family members of those who request medical aid in dying are better prepared and accepting of the death of their loved one, and there are no negative effects. About 90% of those in Oregon who end their lives by medical aid in dying are receiving hospice care, which means that even hospice can't meet all the needs of all dying patients, even though we know that quality hospice can relieve the suffering of the vast majority of patients. Almost all dying patients who use medical aid in dying have health insurance, and most are college educated. There's an excellent article from now 5 years ago written by the former CEO of the Oregon Hospice Association. Initially, she was against medical aid in dying, and she voted against the referendum, which would allow it. But then, over time, she said, however, I came to realize that it was arrogant of me to believe that hospice and palliative care professionals could meet all the needs of the dying. While some healthcare professionals expressed fierce opposition to medical aid in dying prior to the law changing in Oregon, since then, those voices have softened in the face of indisputable evidence, and no representative medical organization has called for the law to be repealed. And I believe that's the case throughout the country. Once you have a law in effect, there really isn't a call for it to be repealed. Why? Because the laws work as intended. Yes, they're not perfect. No law works perfectly, but these laws work about as well as any laws could. There's a comprehensive cancer center in Seattle, similar to Sloan Kettering. It implemented a program for patients who wanted to access medical aid in dying. And what it found was, after a study, overall, our Death with Dignity program has been well accepted by patients and clinicians. None of the problems expected or anticipated by opponents or skeptics of medical aid in dying seem to have emerged. There is no evidence of disproportionate impact on vulnerable populations, a serious concern that was raised when medical aid in dying laws first went into effect. No disproportionate impact on any group, whether it's poor people, people with disabilities, the elderly, people of color, it doesn't matter, simply no disproportionate impact. Nor is there any evidence of coercion or abuse, no court cases, no administrative findings of any coercion or abuse. With regard to those with disabilities, consider the letter from the Executive Director of Disability Rights Oregon, their protection and advocacy agency, where he said categorically that Disability Rights Oregon has not received a complaint of exploitation or coercion of an individual with disabilities in the use of Oregon's Death with Dignity Act. And at that point, the law had been in effect for some 16 years. There is no evidence of any slippery slope, another legitimate concern that was raised back when. Medical aid in dying is only for people who are terminally ill. What is happening in other countries is simply not relevant. We have our own distinct history and culture, values, religious and otherwise. And it's difficult enough just to get medical aid in dying laws enacted only for the terminally ill. And the only way that there could be a slippery slope to expand medical aid in dying would be if legislatures passed laws or if there were court decisions. And every case that has come before courts seeking to establish medical aid in dying by the federal or state constitutions has failed. So there can be no legitimate expectation that we are likely to have a slippery slope when it comes to medical aid in dying. New Yorkers support medical aid in dying by a 2-to-1 margin, including majorities of Democrats, Republicans, conservatives, as well as those of different religious affiliations. Physicians nationwide support medical aid in dying by a 2-to-1 margin. And in New York, once doctors have looked at the Medical Aid in Dying Act and see all of the protections and safeguards in the bill, they support the Medical Aid in Dying Act by more than a 3-to-1 margin, according to a Medscape poll. There are numerous and extensive provisions in the Medical Aid in Dying Act, which Assemblymember Reyes will discuss in a few minutes. But I thank you very much for your attention, except to say medical aid in dying is based on overwhelming evidence, a proven, reasonable, ethical, safe, and effective option for some, although few, dying patients. Terminally ill adult patients with decision-making capacity should have this option available. Thank you.
Thank you very much, David. And now we'll move on to Assemblymember Reyes, who will be talking about the Medical Aid in Dying Act.
Thank you. I am going to share my screen. Here we go. Can everybody see it? I've never shared a screen before. So this is absolutely something new for me. There we go. All right. So New York's Medical Aid in Dying Act was introduced in 2019. It is Assembly Bill 2694, carried by Assemblymember Paulin, and it has the same act in the Senate, S3947, carried by Senator Savino. So the Medical Aid in Dying Act of New York is modeled closely after the Oregon Death with Dignity Act. The New York's Medical Aid in Dying Act aligns with nationally accepted medical standards of care and creates a responsible, effective, and compassionate medical practice that is accessible to patients and provides appropriate protections for participating physicians. New York's bill would authorize medical aid in dying, a medical practice in which a mentally capable, terminally ill adult with 6 months or fewer to live has the option to request a doctor's prescription for medication that they can decide to take to die gently in their sleep if and when their suffering becomes unbearable. Today, 1 in 5 people, that's more than 20% of all Americans, now live in a jurisdiction where medical aid in dying is authorized. That list includes 9 states, as well as the District of Columbia, including Oregon, Washington, Montana, Vermont, California, Colorado, Hawaii, New Jersey, and Maine. We now have over 20 years of experience with aid in dying laws, going back to 1994 in Oregon. The New York Medical Aid in Dying Act establishes strict eligibility criteria, as well as guidelines that meet the highest standards of care for the medical practice of aid in dying, as described in clinical criteria published in the prestigious and peer-reviewed Journal of Palliative Medicine. So some of the key provisions and safeguards include only adults with an incurable and irreversible terminal illness and 6-month prognosis confirmed by 2 doctors are eligible for medical aid in dying. Patients are not eligible simply because of age or disability. The attending physician must inform the requesting patient about all of their end-of-life care options, including hospice and pain symptom management. If either doctor has concerns about the patient's mental capacity, for such a decision, they must make a referral to a mental health professional for an assessment. Medication can't be prescribed until mental capacity is determined. 2 separate requests for the medication must be made, 1 oral request and 1 written request. 2 people must witness the written request. The patient must be able to take the medication themselves, so nobody can administer it for the patient. Anyone attempting to coerce a patient is subject to criminal prosecution. A terminally ill person can withdraw the request for medication, not take the medication once they have it, or otherwise change their mind at any point. An unused medication must be disposed of in a safe and secure manner according to the guidelines specified by the U.S. Food and Drug Administration and New York State Department of Health. And the State Department of Health is required to issue a publicly available annual report. And this slide here that I have gives an overview of some of those safeguards that we've put into the legislation in New York State. So voluntary participation for healthcare providers. A healthcare provider may choose whether to voluntarily participate in medical aid in dying. The bill ensures that no provider is obligated to prescribe or dispense aid in dying medication. However, if a doctor is unable or unwilling to honor a patient's request and the patient transfers their care to a new provider, the prior provider must transfer upon request a copy of the patient's relevant medical records to a new physician. And we've seen a similar scenario with vaccinations in children as well, where there are physicians that choose not to vaccinate or choose not to take on cases of families who don't believe in vaccinating their children. Those physicians who do decide to participate are protected from criminal and civil liability and professional discipline as long as they comply with the law and act within the standards of medical care. Protecting patients in life and their loved ones after death. The New York legislation, as well as each of the laws of the authorized states, explicitly states that wills, contracts, insurance, and annuity policies are unaffected by a terminally ill individual's decision to request or utilize medical aid in dying. That includes life insurance. Because the bill makes clear that medical aid in dying is not suicide and requires that the cause or manner of death is listed as the underlying illness on the death certificate, life insurance companies cannot deny payment to beneficiaries because a policyholder utilized the law. In other words, an individual is entitled to their existing benefits in life and after death, whatever they are, regardless of the availability of medical aid in dying. And the legislation has widespread support from state and national medical groups. And here I have some that includes the, I'm gonna go back. The New York State Academy of Family Physicians, American College of Legal Medicine, American Public Health Association, American Medical Women's Association, and American Medical Student Association. So by a margin of 90% to 3%, physicians agree that any patient requesting medical aid in dying who is not enrolled in hospice when the request is made should be offered a referral to hospice. By a margin of 77% to 10%, physicians agree that a physician who does not practice medical aid in dying should refer a patient requesting this end-of-life care option to a physician who offers the practice as a reliable resource for information to find a physician who offers this practice. And by a margin of 41% to 35%, physicians agree that they would be willing to write a prescription for a patient who qualifies for the medication. And in terms of support within the legislative body, in the assembly, the bill enjoys 37 co-sponsors and 6 multi-sponsors, and it has 13 co-sponsors in the Senate. So this is a piece of legislation that, yes, is very controversial, but enjoys widespread support because we believe it's safe and it's modeled after other pieces of legislation. New York has the opportunity to get it right based on the legislations in other states and their shortfalls as well. So that is all I have. Thank you.
Thank you, Assembly Member. Now we're going to turn it over to Dr. Muller. He's going to talk about why medical aid in dying should be an end-of-life option.
Unmuted, yes. Can everybody hear me? So thank you, Ayana. Thank you to the Academy of Medicine for inviting me to participate. My bio, my little brief bio on the program says that I'm Dean for Medical Education, but I want to clarify that my perspective on this issue, and I think my invitation here is not really based on an educational perspective in medical practice. It's based on my clinical perspective. For about 25 years, I've worked in a program that we have at Mount Sinai called Visiting Doctors, where we take care of people who are homebound. And so the patient population we care for is predominantly very elderly, frail, chronically ill, terminally ill, and people who want to be home to receive their care, can't really get to the doctor easily. And if and when the time comes for them to die, they want to die at home too, which is, we know from much of the literature, what most of us want. So my understanding of this issue really comes from that clinical practice. I also want to point out, and again, some of what I say is going to sound repetitive, but the words mean a great deal. Why medical aid in dying should be an end-of-life option. I'm not here to talk about the fact that medical aid in dying is the right thing to do for a particular patient. I'm not even talking about whether I would do it in particular circumstances, but it should be an option, and it should not be something that I or my professional organization or a religious organization or anyone else regulates or prevents people from having access to. So this is really about making it an option as opposed to precluding people from participating in it. I want to also start with a little bit of an anecdote. So I saw a patient just last week, a patient that I've known for about the last 6 months. She's 95. She likes to tell me over and over again that she's going on 96, which I realize because she's 95, and is mentally, cognitively, emotionally completely intact. A brilliant woman, a little bit physically frail, gets around the apartment with a walker, but otherwise is perfectly fine, one would say. And I can never find anything wrong with her when I do my physical exams, and she's quite proud of that. And she talks to me. She has brought up on a number of occasions, in fact, every time I see her, the fact that she wants to die. She's pretty explicit about it. I want to take something and end this all. And when I ask her why, it's because she's 95, everyone is gone, her children and grandchildren are, but her whole social circle, and she just doesn't see the point of continuing to live. She's not depressed. She has no mental illness whatsoever. And I use her as an example, not because we're talking specifically about aid in dying for someone like her, but because the first point that I want to make is that from a clinical perspective, all patients, all people deserve a safe space to talk about this issue. Everyone thinks about it. And I'm not making that bold statement because I know what the literature says, but every single patient I've ever taken care of who either is very elderly and knows they're facing the end of life at some point or is terminally ill, it's on their mind. And the idea that we as physicians can't or won't speak to our patients about something that is potentially making them very anxious, very vulnerable, and creates a barrier for the rest of the kinds of communication we have to have is completely inappropriate. People think about aid in dying. They think about what it might be like to hasten their death. They want to know what their doctor thinks about it, especially if they have a good relationship with their doctor. And sometimes they want to know if the doctor will help them, will support them in that. From that perspective, I think it's a doctor's duty to talk about this issue. It can't be something that we're gagged because it's illegal. It can't be something that is what abortion used to be like or what marijuana used to be like. It has to be something that we are comfortable having a conversation about to reassure patients that we will accompany them throughout the course of their care, that we will support them in whatever decision they want to make. And if we as physicians are comfortable carrying out ultimately something like medical aid in dying, then that's great. And if we're not, as was said before, we have to be in a position to refer them to someone who will do that. To not do that is an incredible neglect of duty. I think of the physician's duty to inform and protect and reassure and support their patients. So from that perspective, the patient that I spoke about earlier, we had quite an extensive conversation. I explained to her what it would be like in the state of New York. You can't just get a prescription, it's illegal. And by the way, if you can get a prescription, it really takes quite a bit of an effort to take that, to swallow the medications we're talking about. So what can you do in a state like New York? What about stopping eating and drinking? And the conversation was, I think, really reassuring for her because she understood what the options were. But most importantly, she knew that as this topic comes up in her mind over and over again, I'm someone that she can talk to about it. It's not taboo. I won't think any more or less of her because this is something that's on her mind. To speak to some of the points that were made before by Assemblymember Reyes and by David Leven, there are a host of reasons that patients should have access to medical aid in dying. From a medical perspective, and again, I'm talking about both the literature and my own experience, we can't always control pain. There's no such thing. Any doctor that reassures a patient that we can always take care of pain and manage it is absolutely not true. We certainly cannot always control debilitating symptoms and suffering. We absolutely can't get a handle on patients who have existential suffering. There's a lot of what happens to people at and near the end of life that medically is not something that we can reassure people with a lot of confidence that we can always take care of so that they don't have to deal with that suffering all the way to the end of when they pass away. I also think that there's an important aspect of it that has to do with a patient's dignity, their autonomy and agency, and their independence. Sometimes people who are terminally ill want to talk about aid in dying, not because they have intractable pain, but because they don't want to be a burden for their families. They want to be able to have a conversation about what that means and the ability to maintain their independence as a thinking adult and decide that it's really enough. It's been enough for them with a course of illness or a course of life, and it's really enough in terms of what they're putting their family through. And again, I'm not making the case that that is a good reason, in quotes, a good reason, to write someone a prescription, but the ability for patients to have that option, to have the conversation, and if the need arises to follow through with it, I think is critically important. And so from that perspective, I think I'm just to go over again, the key points for me, as physicians, we have to be prepared and equipped to talk to patients about this. We have to be able to provide them with what the options are wherever it is we're practicing, in some of the states where it's legalized, or a state like New York where it is not yet, and provide them with a range of possibilities that are open to them. We have to feel comfortable following up on that, even raising it ourselves, and not putting a patient in a position where they have to figure out whether it's safe to say it or not. And depending on the circumstances, we have to be prepared on an individual basis, right? We're not talking about all doctors doing this. We have to be prepared to act on it in some way. Again, if I go back to the conversation I had with my patient, who really appreciated it, I told her the next thing that we do, if she wants to keep talking about this, is bring the rest of her family into this conversation. Everybody has to be aware of what her wishes are, and everybody has to respect those decisions, even if they don't completely agree with them. And she was very happy to hear that that's the approach that we would take. So those are my comments. I'm happy to answer questions as they come up in the chat a little bit later in the session. And thank you very much.
Thank you, Dr. Muller. We really appreciate your perspective. Now we're going to turn to Dr. Dugdale to talk about why medical aid in dying should not be an end-of-life option.
Thank you, Ayana. Laura, would you be able to pull up the slides? Wonderful. Actually, if you want to just, sure, great. Thank you. So I'm delighted to be here, and I thank the host for the kind invitation. And I absolutely concur with my colleagues. There is no physician I know who wants patients to suffer. And indeed, suffering at the end of life was one of the issues that drew me to medicine, and it's actually informed a lot of my work, a lot of my scholarly work, and it's even the subject of my most recent book, which I just published, on how to die well. So this is something that matters to me enormously. I am a doctor. I'm a primary care doctor, so I take care of patients in the outpatient clinic, and I have had these conversations with many of my patients, and I agree with Dr. Muller. It's something that doctors need to be prepared to talk about. As with almost any issue that our patients bring up, we need to be able to engage with them on questions that matter to our patients. That's a part of respecting their dignity of persons. So we are on the same page. But when we physicians think about whether we should advocate for a particular treatment, we weigh the harms and the benefits. And in the case of medical aid in dying, or what some call assisted suicide, and I'll talk about that, I believe that the harms outweigh the benefits, and therefore I cannot support its legalization. If you'll skip to the next slide, and then the next one, please. There are many reasons to be opposed to assisted suicide, but I'm going to highlight three. First, it is dangerous. Second, it is discriminatory. And third, it pressures people to die by assisted suicide when it is legal. Next slide, please. First, it is dangerous. And I'm going to sort of go through this from many different perspectives. So next slide, please. It is not medical care, okay? We doctors, we receive no training as medical students or in residency for it. We have no standard guidelines and no standard treatment. I know someone asked in the chat about the drugs. We'll get to that. We actually don't agree on the best treatment. There are two common cocktails in common use right now. Next slide, please. We've tried a host of drugs and cocktails over the years, but these are all experimental. There is no review board oversight or approval by the Food and Drug Administration for the purposes used. And in the case of chloral hydrate, that's the Mickey Finn drug that people were slipping into drinks to cause people to pass out. And we found that this was far too caustic to give to patients. Next slide. Furthermore, people with depression can access the lethal drugs without psychiatric evaluation. So for example, we know that the vast majority of patients who are elderly with advanced cancer have clinical depression. We also know that the vast majority of those requesting lethal prescriptions in Oregon or Washington, for example, are elderly with advanced cancer. Yet over the past 22 years that the bill has been legal in Oregon, fewer than 4% of patients have been referred for psychiatric evaluation. Next slide, please. Furthermore, there is no residency requirement to obtain the lethal drugs under the proposed New York assisted suicide law. So this means that New York State could become a national suicide tourism destination akin to what is occurring in Switzerland. Next slide. What's more, there is no waiting period to receive the lethal prescription. This raises the possibility of people ending their lives on an impulse, right? We know that this happens. And it enhances the ability of people to travel to New York State, whether from other states or abroad, to request assistance with suicide. Next slide, please. Once the drugs are dispensed, there is no oversight. So in contrast to my colleagues who describe the oversight that is in place or the safeguards that are in place, once the drugs are dispensed, no one is checking up on this. Keep in mind that according to the National Council on Aging, at least 10% of the elderly in this country are abused. I'm a primary care doctor. I've taken care of countless, no, that's wrong. I've taken care of numerous patients whose adult children have been after their will or their inheritance. And I've had patients whose adult children have pressured them into stopping treatments and they have died prematurely. We should not pretend that this is going to be completely exempt from abuse. There's no reason to think that the lethal drugs cannot be crushed and forcibly administered. And also, it is worth pointing out that in contrast to the laws around the country, the New York law actually allows for injection of the drugs by self-administration. So definitely by self-administration is what's written into the law, but there's no oversight. So this self-administration or self-injection of these drugs is similar to the method used by the infamous Dr. Kevorkian. Next slide, please. Second, assisted suicide is discriminatory. Now, legalization of assisted suicide creates a new group of human beings who are denied protection of the law afforded to others. So what do I mean? So think of it this way. Suicide, conventional suicide, is not illegal. In fact, it is legal in every US state. But it is discouraged in almost all societies. Assisting a conventional suicide is illegal because the law recognizes the potential for abuse, undue influence, and coercion, all of the things that one might worry about with any type of lethal substance. Assisted suicide laws effectively deny suicide prevention to this new class of people. The implication being that their lives are less worthy of protection of the law. Now, I know, and as my colleagues have said, that many in favor of legalization of assisted suicide are quick to point out that it is not the same as conventional suicide. Mr. Leven pointed this out, and in one sense, he's absolutely right. Physician-assisted suicide allows for more control, for example. It allows for families to plan. It is state sanctioned, and for those who prescribe it, it is physician approved. But the word suicide, the word itself has always meant self-killing. This is the etymology of the word. So whether a physician provides me with a lethal prescription and I ingest the lethal drugs and become dead, or whether I steal a gun and shoot myself and become dead, both cases are suicide. Both cases are self-killing. Next slide. In Europe, the term assisted suicide or accompanied suicide is preferred. So this is an excerpt from a brochure from a place called Dignitas in Switzerland. This is one of the places that you can actually go to. It costs about 10,000 euros. And you can go and with your family and take a lethal prescription and die in one of the chalets that belong to Dignitas. And you can see that the Dignitas brochure is very comfortable with the language of suicide, accompanied suicide or assisted suicide. And in fact, this brochure, which is available online, goes on to describe the drug cocktail and the method for completing the suicide. But again, my point here is that suicide is the preferred term. Now, next slide, please. The data suggests that suicide begets suicide. And that, in fact, the legalization of assisted suicide is associated with more assisted suicide as well as conventional suicide. Next slide, please. A study of rates of assisted and unassisted, okay, so both kinds of suicide in Switzerland from 1991 to 2008, showed that the rates of suicide of both forms, okay, tripled in older men, demonstrated by the orange lines here. And the data from our own country bear this out as well. Next slide, please. In Oregon and Washington, deaths by assisted suicide have steadily increased. Additionally, both states have always had higher numbers of cases of conventional suicide relative to the national average. Next slide, please. But in recent years, the numbers of conventional suicides have disproportionately increased. So the idea being that the longer that the death with dignity laws have been around, the assisted suicide laws have been around, the more comfortable people are becoming with self-inflicted death. Now we have 44,000 suicides a year in the United States, which we actively work to prevent. We, as a society, we believe in preventing this. So it becomes discrimination then for medical professionals and state governments to endorse suicide for some people and to oppose it for others. Next slide, please. My third point, if legal, assisted suicide will pressure people to die this way. And this is probably what I find to be the most concerning. So once we make it legal to help patients end their lives, it's difficult to go back. Last week, this report came out by Canada's Parliamentary Budget Officer, and it looked at cost savings by implementing MAID in Canada and projecting them forward. With expanded access to MAID, the Canadian government anticipates saving $149 million in healthcare costs. Next slide, please. In fact, in his own book, assisted suicide advocate Derek Humphrey notes that the economics, the money, not the quest for broadened individual liberties or increased autonomy, but it's the money that will drive assisted suicide to the plateau of acceptable practice. It's a no-brainer that health systems will save money where they can. And we're seeing it with assisted suicide. Next slide. Barbara Wagner was denied coverage for her chemotherapy, but instead her insurance plan through the state of Oregon offered her a lethal prescription to end her life by death with dignity. Next slide. Randy Stroop was also denied coverage for his chemotherapy and instead offered coverage of lethal drugs by the state of Oregon insurance plan. Next slide, please. Stephanie Packer in California was denied payment for life-saving treatment. And when she asked her California insurance provider why they wouldn't pay for the treatments, she was offered less expensive lethal prescriptions. Next slide, please. Dr. Brian Callister has patients in both Oregon and California whose life-saving treatments have been denied, but their insurers instead have offered them assisted suicide. Once a society embraces assisted suicide as an acceptable answer to suffering, and I care immensely about human suffering, but once we embrace this way to take care of suffering, it becomes a cultural and economic imperative. Next slide, please. We stop seeking to help the suffering live. We offer lethal drugs instead of life-saving treatments. We don't refer those with depression for psychological evaluation. Next slide, please. And we send COVID patients back to their nursing homes to die rather than treating them for the COVID in the hospital, as happened in Belgium, where euthanasia is very common. And actually, it's described here in the New York Times. So if the moral test of a society is how it treats its most vulnerable members, and politicians throughout time have said this, that the moral test of a society is how it treats its most vulnerable members, then the spread of physician-assisted suicide sets our society up for significant moral failure. And that's my concern, and I would love to hear questions from the group. Thank you so much for the kind invitation.
Thank you so much, Dr. Dugdale. Appreciate your perspective. And now with our final speaker, we'll turn it to Mary Ellen Trisgallo. She's talking about a nursing's perspective on this issue.
Laura, can you pull up my slides, please? Hello?
We can see your slides on the screen.
Oh, you can. I'm sorry. Let me just move them over. Thank you very much.
Oh, sorry. Now we see your desktop.
Yep.
There we go.
Okay. Thank you very much for inviting me to be here today. In presenting a nursing perspective on medical aid in dying, I will reflect with you on how I see the role of the nurse in MAID. Prior to beginning, however, I offer transparency. Although I respectfully recognize that there be a plurality of views on this issue, I am not neutral. I am opposed to the passing of the New York State bill titled the Medical Aid in Dying Act. In any event, in the next 10 minutes, I will first review some concerns I have regarding the proposed legislation as it currently exists. In the second part of my presentation, I will speak about the role of nurses, the role that nurses might play were this bill to become law. Point 1, medical aid in dying is assisted suicide. What Assembly Bill 2694 proposes falls squarely within the legal definition of assisted suicide. Myers versus Schneiderman cites Black's Law Dictionary. Assisted suicide is the intentional act of providing a person with the medical means or the medical knowledge to commit suicide. Scrubbing the word suicide from the bill, the Medical Aid in Dying Act does not change what it really is. American law recognizes a right to die. Death, of course, is certain after all. However, it does not recognize a fundamental right to assistance in committing suicide. Point number 2, state prohibitions against physician-assisted suicide, including New York's, are recognized as promoting legitimate governmental interests. The US Supreme Court outlined these interests as prohibiting intentional killing and preserving life, preventing suicide, maintaining the physician's role as their patients' healers, promoting vulnerable people from indifference, prejudice, and psychological and financial pressure to end their lives, and avoiding a possible slide towards euthanasia. Point number 3, drafters of A2694 attempt to soften or mitigate assisted suicide's potential threat to these governmental interests by committing to certain safeguards. They determine whether a MAID request is an informed decision. They determine voluntariness of the MAID request so as to root out decisions that are the product of coercion. Of note, this is undefined in the legislation as proposed. There's a 2-physician fail-safe mechanism to avoid bias or mistakes of a single physician, and rules about who may witness the execution of a MAID request so as to limit the involvement of patients who may have personal or financial interests in death of the MAID requester. Point number 4, the real-world efficacy of any safeguard will be a function of institutional commitment, cost, and availability. For example, determining whether the medical aid in dying request has triggered or influenced by an underlying or financial pressure. How much in resources is an institution willing to commit to getting this right in every case? The true value of palliative care option to a MAID in dying requester demands availability, quality, and cost of such care. Will costs be structured to incentivize MAID over palliative care? Mental health evaluation seems only relevant to evaluating decisional capacity. Should there not always be meaningful psychiatric evaluation to determine if depression or other mental illness is playing a role in the MAID request for someone that is making it? Point number 5, palliative and hospice care does not equal medical assistance in dying. A central aspect of the World Health Organization's definition of palliative care is that it neither hastens nor postpones death. The American Academy of Hospice and Palliative Care Medicine and the Hospice Palliative Nursing Association are committed to state-of-the-art palliative and hospice care that focuses on alleviating many sources of suffering associated with advanced illness at end of life. The biopsychosocial interdisciplinary team approach seeks to relieve suffering and to ensure quality of life while upholding respect for patients and families' values and goals. Palliative care and hospice providers are experts in the management of distressing symptoms and pain, spiritual and psychological distress. Patients with capacity can decline unwanted care, advance care directives, goals of care discussions, guide medical decision-making, and there are accepted standards that exist for palliative sedation. The ending of suffering by ending life is held as distinct from palliative care, which relieves suffering without intentionally hastening death. Point number 5, there is a workforce shortage of board-certified palliative care hospice and hospice specialists. Scarcity of specialists projected into the future exists. End-of-life care will fall primarily on generalists and specialists. Hospice statistics of 2019 point out that New York State ranked 49 out of 52 states for decedent Medicare enrollment percent in hospice. It is also important to note that in the 2019 statistics, 40.5% of patients received hospice care for less than 14 days, while only 14.1% received hospice care for up to 180 days. 54% of patients were enrolled in hospice for 30 or fewer days. It is also important to note that the oldest patients were Medicare recipients, and most of them were over the age of 80, as one might expect. And it is also important to note that 90%, almost 90% of patients who were in hospice received only routine home care. For anyone who's had an elder or a parent or a patient in hospice that has been receiving only routine home care, one has to wonder whether or not that level of care really does in fact support the patient that needs that care. So some of the factors that might affect decision-making for patients and certainly for families, but I would focus on patients, is the quality and availability of palliative and hospice care to meet the present and growing needs as baby boomers age and live longer. Certainly the issue of family caregiver stress is a factor in how it is that someone may or may not consider a request for medical aid in dying. There's an increasing sense of loneliness, isolation, and lack of support systems that we know are existent in our society because of the way that we do or don't live in community. And as people become older, they lose a sense of hope, meaning, and connection. They lose a sense of purpose in people. So the question is not to have the conversation with them, but the question really becomes, what should the conversation be? And how can we really add to what it is that's important to talk about with regard to how it is that we work with elders? Point number 7, who are the nurses in this discussion? Nursing is a highly regarded profession, publicly ranking first in Gallup polls for honesty and ethics. Nurses comprise the largest sector of the work care force with more than 20 million nurses worldwide and over 4 million nurses in the USA. The ANA states that nursing is the protection, the promotion, the health, the prevention of illness and injury, the alleviation of suffering, and the advocacy in the care of individuals, families, communities, and populations. Nursing ethics encompasses social ethics, the moral rightness and goodness in shaping of human society. Nurses spend more time with patients at end of life than any other healthcare team member. Nurses play a fundamental role in the care of those that suffer. Point number 8, the ANA position statement, which was approved in 2019 and developed by the ANA Center for Ethics and Human Rights for the nurse's role when a patient requests medical aid in dying, states the following. It affirms nurses are ethically prohibited from administering aid in dying medications. It states that the patient must obtain, prepare, and self-administer those medications. It distinguishes medical aid in dying from euthanasia. It maintains euthanasia is illegal in the United States and inconsistent with the core commitments of the nursing profession and that it profoundly violates public trust. It advises nurses to remain objective, however, to assert their ethical duty to be knowledge about this evolving issue, to respect patients' self-determination to make voluntary autonomous choices, and to remain non-judgmental and protect confidentiality for all parties. It also allows the nurse the right to conscientiously object to being involved in aid in dying process. Moving forward, I will not talk off slides, but I will talk off what it is that I have written for you. Point number 9, evolving conflicting standards for nurse practitioners. In Canada, Bill C-14 permits physicians and nurse practitioners to prescribe and administer medications to capable patients who have a grievous and irremediable medical condition where natural death is foreseeable. This is the only place in the world that I am aware of that in fact does that, or at least in terms of North America that does that. However, no state in the United States currently allows nurse practitioners to diagnose a terminal illness or to prescribe medical aid in dying. The New York State Assembly bill, however, could shape the role of the nurse practitioner. It proposes to allow nurse practitioners to participate in medical aid in dying if he or she qualifies as a mental health professional by training, clinical expertise, or certification. This would be for the evaluation of a patient in terms of not only capacity, but also in terms of mental health. I do say, though, that all nurses should know how state law affects their civil and criminal liability. It is absolutely essential as we move from where we were to where we are and where we may be going. Now I just want to point out in point number 10, why it is that the nurse is especially important in this. The nurse is a compassionate advocate, uniquely positioned to understand a patient's needs, concerns, and intentions. Nurses recognize, alleviate, and bear witness to suffering. They provide human connection, reassurance, compassion, and understanding. The patient-nurse relationship has been described as an analgesic. It is the most intimate to the care of patients and families. Nurses balance complex roles as direct care providers, listen, advocate, and mediate. Nurses are often the profession in whom most individuals confide and share their burdens and their worries and feel safe to ask questions. They are not the only profession, but they are often the profession because they spend the most time with the patient. The nurse can be the first to hear the words, "I want to die." The most important predictor of how well a medical aid in dying death will go is the presence of a nurse, or the words of a physician at an international conference describing experiences with medical aid in dying in Canada. Point number 10, why are these qualities of nurses so critical both to medical aid in dying? Nurses are uniquely positioned to gain a deep understanding of a patient's choices and vulnerabilities. They have an obligation and a duty to serve as an essential spoken voice in representing the interests of patients and families. It is therefore difficult to imagine a medical aid in dying as fully honoring the intentions of a patient without a nurse, in particular in connection with the deliberative safeguards. The critical role of nurses in MAID is becoming increasingly recognized. The Canadian documents caution nurses to know their role in ensuring safeguards are met. In summary, they also said that when assisted death is legal, the nursing role seems considerably more substantial than what might be assumed from the amount of evidence published about the nurse experience. I will end with a reflection from Atul Gawande. Everyone dies. Death is an inherent failure. Death is not an inherent failure. Neglect, however, is. I came across this quote by Atul Gawande that speaks to death not as a tragedy, but as an inevitability. This quote speaks to my concerns about the proposed legislation for the Medical Aid in Dying Act in New York State and to the role of the nurse in this proposed legislation. May we never look back to say that we neglected our patients or compromised our moral compass as medical professionals, legislators, administrators, or laypersons in assuring that we advocated for the interests of society and in using our spoken voice for the needed safeguards in the protection of others. Thank you.
Thank you, Mary Ellen. So we've definitely had a very interesting conversation today with a lot of different perspectives. For those of you who've joined us late, please write your questions into the chat and I will be reading them and directing them to the appropriate person. If you have a question for a specific panelist, please note that. Otherwise, I'll kind of generally ask them or ask the person who might give the best response. So it was clear from the presentations that there's use of different terminology versus looking at assisted suicide and medically aided dying. So I just wanted to give an opportunity for David Leven to respond to some of those issues and differences.
I think it's important, as I mentioned in my discussion, the American Association of Suicidology has 15 points of distinction in its statement between what they call physician aid in dying and assisted suicide. I just want to mention a couple of them because they really are distinct regardless of the traditional definition of assisted suicide. One is the term suicide may seem to imply self-destruction, and the act may be cast that way in some cultural and religious traditions. Ending one's life with the assistance of a physician and with the understanding of one's family is often viewed more as self-preservation than self-destruction. Acting to die while one still retains a sense of self and personal dignity before sedation for pain or the disease itself takes away the possibility of meaningful interaction with those around one. The other point I'll make of the 15, and there are 13 or 14 others, is that in suicide, the person often sees no way out of their desperate situation. Under the physician aid in dying statutes in the US, the physician is required to inform the patient of all feasible alternatives for relieving their situation, including comfort care, palliative care, hospice care, and pain controls. And just to the point that was just raised by Mary about hospice and palliative care, we completely agree that it is so essential for most people to be in hospice if they possibly can be, or palliative care at the end of their lives, even though New York ranks very low in terms of providing hospice care. But there is no connection between medical aid in dying and lack of access to palliative care or hospice, as we see in the states which permit medical aid in dying, as the vast majority of people who ultimately access medical aid in dying are receiving hospice and or palliative care. So there is no denial of access. We have a concern about access, but again, no connection to medical aid in dying. And the last point I'll make is that Lydia raised a lot of concerns, and understandable, again, 15, 20 years ago. Those concerns have absolutely been mitigated by all of the data which has come in from all the states over a cumulative period of 70 years now, which shows that those concerns just were not valid when they were raised then and being raised now. There have been a few cases where mistakes have been made. There's no question about that. Mistakes will always be made. And the concern about people possibly being coerced, there's lots of morphine in the home of people who are in hospice care, and we don't know what's happening with that morphine and who's going to be administering it and how much is going to be administered. But we allow it to happen, and so there can be mistakes, there can be things that happen, unfortunately, with medical aid in dying, like everything else. But those are not sufficient reasons in opposition to the compelling reasons to allow the process of medical aid in dying for those people who want to access it, with, of course, 2 doctors being significantly involved. And no, we don't have a residency requirement in New York under our bill. Why? Because there's no residency requirement to get health care. This is a form of health care. That's according to Assembly Member Dick Gottfried, who is one of the lead sponsors of the Medical Aid in Dying Act. There is also no waiting period, just as there's no waiting period for a person who says, please withdraw the ventilator. You go through a process, though, because the process should be gone through. You try to make sure that the person, there's nothing more that we can do for the patient so that to improve his or her quality of life so that he or she wouldn't want medical aid in dying. And that process is going to take some period of time. And in fact, the average amount of time it takes from the time that a person makes a first request for medical aid in dying and the medications until the time that he or she takes it is about 7 weeks. This doesn't happen impulsively. It doesn't happen quickly. It's a process and we should be going through a process, and we should try to ensure that everyone is getting good quality hospice and or palliative care before they take the medications.
If I could just jump in to clarify something with the New York bill, in contrast to other states which do require a waiting period, I think 15 days is a typical one. New York doesn't have a waiting period, which means that all a patient needs is 2 physicians to confirm that he or she is eligible, and then the prescription can be written. So effectively, you could have within a 24-hour period a lethal prescription, which is concerning when you're not systematically screening people for depression. And again, the numbers of studies that show that older folks with cancer suffer from depression is incredible. And also, as a primary care doctor, the fact that more than half of primary care doctors miss cases of clinical depression is concerning. So the fact that we are not really systematically screening people for depression opens a floodgate of potential for prescribing these drugs for people who are acting impulsively, coming to the state one day and being dead the next. And that's not what I think anyone on this call would advocate.
Yeah, may I add something to that, Dr. Dugdale? And thank you, Mr. Leven. We talked a little bit about the large majority of physicians, at least by survey, being in favor of physician-assisted suicide or physician-assisted death, or being proponents of the legislation. The reality is that they may be proponents, but a very small percentage of those persons that actually are in favor of the legislation, at least if we look at the experience in other states, will be writing those prescriptions themselves. So I want to take a moment to pause to Lydia's point and to your point here also is, should it not be the person who knows the patient best, that really has an understanding of who this patient is from the inside out, contextually, that has a long-standing relationship with this person? Should they not be the person or the physician or the professional that's writing that prescription who can really then provide the safeguards? That is what it is that we intend those safeguards to really be able to do, which is to do it right, as you say. So a small percent of people will be writing these prescriptions, professionals. They may not or will likely not be the physician who is taking care of that patient because of their conscientious objection. And I would say that that in some way violates in some way the sanctity of one of the protections, which is what we all advocate for, is the care of this patient, not in the context of writing a prescription, but in the context of making sure that whoever writes that prescription actually knows that patient best or knows that patient well enough to be able to know whether this person needs a mental health evaluation, whether this person's being coerced, what it is that the true medical facts about their diagnosis and prognosis is. So if people are coming in from out of state and there's no relationship here, then one of the basic tenets, which I think is what we all do in the work that we do, is build on relationships so we can make decisions with our patients and families that are actually in their best interest.
Thanks. And I just wanted to say, Dr. Muller, do you have anything to add to this discussion?
The only point that I would make, and I don't want to diminish in any way the complexity of the conversation that's happening, but the sanctity of the relationship between the physician and the patient is about the patient. It's not about the doctor. And so I want to make sure that we're framing that in the right way and that we agree upon that, so that if a particular doctor is not comfortable with, or it's not consistent with their cultural, religious beliefs, or whatever the case may be, the patient as the center of this relationship should have the right to go to someone, even if they haven't known them for 20 years as a primary care doctor, and say, this is what I need. I need someone to talk to me about this issue. I need someone to help me figure out whether it's the right fit for me, and not have it rely on a doctor, because the doctor is not really the center. And I know we all agree on that, but the healthcare provider, I'm not even going to say doctor, it might be a nurse, it might be someone else. The sanctity is about the patient. And if a patient wants that option to explore it, to talk about it, and ultimately maybe even to act upon it, they should have the right to do that.
Thank you. I want to get into a couple of the questions from the chat. That's okay. So we have a question here about Alzheimer's. And so what about people with advanced Alzheimer's in the final stage, the last 2 years? Can you talk a little bit about how they could access or not access this legislation?
Well, if they have advanced dementia, presumably they do not have decision-making capacity any longer, at least to the extent to make their own medical decisions. And so they would not be eligible for medical aid in dying. It's only people who are considered to have decision-making capacity, again, as determined by two physicians.
Would they, I guess the question also speaks to, would they, before their dementia progresses, would they be able to request medical aid in dying?
No.
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 Okay. I see another question here. In terms of prognosis, can a nurse practitioner or physician assistant be one of the two people confirming the prognosis? Does it have to be two physicians? Can a nurse practitioner prescribe the medication?
So I can respond to that. Thank you for the question. The answer to the way the law is currently written is that a nurse practitioner cannot prognosticate in terms of life expectancy, and that a nurse practitioner right now in the United States cannot write a prescription for assistance, medical aid in dying.
Thank you. I have another question here. How do you address a patient's request to move to a state where medical aid in dying is legal, especially now that New Jersey has passed the law? So I guess I would ask the physicians about this question, maybe Dr. Muller or Assembly Mayor Reyes, how that would work.
I can only say that that's tragic. If a patient has been pushed to the brink where they desperately want this option, and the only way for them to do it is to go to another state, we have just fundamentally failed them. In the same way that we failed someone who feels like they have to go out and buy a gun or jump out of a window or harm themselves in a violent way because we as a profession or as individual practitioners aren't prepared to talk to them about something that is really a compelling need that they have. So I don't know, I mean, from a clinical perspective, if a patient came to me and said, listen, I'm thinking of getting care in New Jersey where my daughter lives because I can't get this here, I would encourage them to do so. I mean, personally, I wouldn't, because I'm comfortable having those conversations and then seeing how that plays out. But if ultimately push comes to shove, they need to be somewhere else, I would support them in any way that I could. But again, I will say that I think that that's tragic.
Although it's true that there are different resources available in different parts of the country. So at Columbia Presbyterian, we routinely have patients fly in from other parts of the country because what we offer is not available in rural Idaho, for example. So, I don't know. I mean, the tragedy that our healthcare is so, there are such huge disparities in healthcare is probably the greater tragedy, not whether, medical aid in dying is available in New York versus New Jersey. I think there are much bigger issues here about disparities in access to medical conditions and treatments across the board.
Yeah, I mean, the difference for me, just to sort of chime in, for me again, and I don't want to turn into a whole debate, there's a huge difference between tertiary or quaternary care that a handful of places in the country provide, and this, which to me is a fundamental human need. Not that everyone wants assistance with dying or hastened death, not the case at all, but it is a fundamental human need to be able to talk about my own death and my ability to manage, control that in any way that I possibly can, that gives me comfort and reassurance, even if I never plan to do anything about it.
Dr. Muller, I agree with you 100%. I mean, there was some early data that came out from California where people who were requesting assistance with assisted suicide effectively went in and were able to speak with counselors and talk about their death anxiety. And after they did that, 50% of them left without a prescription, because what they really wanted to do was to be able to have these conversations about their fear of death. And I think that is where, whether we agree it should be legal or not, we as doctors and nurses, we have moral obligations to be there for our patients, to have these tough conversations. And I have colleagues, other primary care doctors, who say to me, I won't even talk to my patients about death because I myself am so afraid to die. And that's a failure. We're failing our patients if we're not going to go there. At the same time, one thing that hasn't come up today, which I'd be curious to hear your take on, Dr. Muller, is, so much of the way this has been framed is the patient has a right, the patient has a right. I fully agree that if we as a democracy vote to make this legal in every state, that once we vote to make it legal, then it should be offered. My problem is that I don't believe it should be the physician who has pledged to be there with the patient to the end. It shouldn't be that same person who is then making the patient dead. And I think that's where, I think we have to be really careful about who we want to be essentially writing the prescription. And I would love to hear your thoughts on that.
Yeah, so my thoughts are that it is my duty to accompany the patient to the very end. I don't believe in euthanasia, so let's not talk about, I know we're not talking about that, so let's set that completely aside. You used the words, and I know we're just sort of having a conversation here, to make the patient dead. I'm not even sure what that means. If I'm part of a process, a legal process that allows me to have a conversation, to pull another physician into the process, to write a prescription so that the patient can keep it in their nightstand, so that they can keep having that conversation with me over the days, weeks, months, as they near death. If they ask me to be at their bedside while they take the medication, I would consider that to be the greatest honor and privilege that a patient could afford me. That even in that most vulnerable moment, when they're most afraid, but they feel like they've made the right decision, the person in their medical life they trust most, presumably me, but it might be a nurse or a nurse practitioner, that's who they want by their side as well as their family. I think that's where we belong.
If I may make a comment on the physician's role with regard to medical aid in dying as opposed to withdrawing life-sustaining treatment, it seems to me that a doctor is much more actively involved in the resulting death of a patient when a ventilator is withdrawn than when a doctor prescribes medication for a patient, when the patient is the one who must make the final decision to either take the medication or not. And so it's the resulting action of the patient in medical aid in dying as opposed to the action of the doctor, which actually causes death.
Well, I think it's also just important to be very clear that there's a long-standing distinction in medical ethics between withdrawal of life support and then providing a lethal prescription. And the reason why there's this distinction is because when we withdraw life support, the understanding is that the underlying disease will take its course, but the underlying disease doesn't always kill a patient, right? Not right away. We've removed life support and people have lived for 10 years. And so we don't then go, if our goal in removing life support is death, then we would either take the patient's pillow and smother them or inject potassium chloride, right? But we don't do that because our goal is not death. Our goal is to remove the technological impediment to sustaining life or delaying death.
And so the goal of the doctor may not be death either, though. When the doctor prescribes life-ending medications for a patient, the goal of the doctor may not be death at all. In fact, the doctor may not want the patient to take the medications. Again, going back to Dr. Muller's point, it's really about the patient and the patient's intent. And that's what should control. It's not about what the doctor's intent is or what the doctor's goal is at all. The doctor may want the patient to die or not. When life-sustaining treatment is withdrawn, that may be the doctor may have one goal or another for the patient to die or not. The same is true when he or she prescribes the life-ending medications.
And I just thank you for the exchange. I just want to make sure I'm asking the questions that have been asked. We have about 10 minutes or so left for the discussion. Assembly Member Reyes, are you still on the Zoom?
I am.
I wanted to ask someone to ask the question. I mean, we're thinking a lot about politics. Someone said, what might be the impact of a more conservative Supreme Court on the existing state made laws and on additional states adopting such laws? Can you talk a little bit about that? Sure.
I think any legislation that we pass is subject to review on its constitutionality. And we've seen with numerous legislations that after they pass and they become law, they get challenged in court. And that could possibly be the case. But I wanted to add something also regarding the waiting period. You know, the legislative process, the bill is introduced right now, both in the Assembly and the Senate, and it is sitting in the Health Committee, which means that we would have to convene as a legislature and vote it out of committee. And I'm not sure if from the Health Committee it goes into another committee until it finally reaches the floor of the legislature. And then after we pass it, the governor would have to sign it and make it law. Within that time, there are numerous opportunities in which we can make amendments. So if we decide in New York State that we want to add language to include a waiting period there, that's absolutely still possible. And that's why I believe conversations like these are so important, so as legislators, we can hear what the medical the medical profession is thinking, what the physicians are thinking, what the nurses are thinking, and what patients in New York State are thinking. So we can make this legislation as strong and protective as possible for practitioners and for patients as well. And we want the end goal to be for people to have this option safely and for families to be protected. So, you know, moving forward, again, like I said, it can be challenged in court. Many legislation gets challenged in court. Sometimes it stands, sometimes it doesn't. I believe that this legislation would stand because there's precedent based on where other states are with this.
And then also I wanted to ask you a follow-up. There's been a little discussion in the chat about the role of insurance companies, and that was referenced in some of the presentations. Can you speak to that a little bit as well?
Again, that's something that we can address in terms of legislation. We were having similar discussions when we were talking about surrogacy in New York State and whether it be something that would be covered by health insurance. And I would leave, unfortunately, I'm not the bill sponsor, so I don't know where they are on it being something that's covered by health insurance and to what extent it's covered and how much of it would be out of pocket, if any. But again, those are conversations that are still being had, and we can determine whether it's something that we would like commercial insurance or Medicaid or Medicare to cover in the future.
Thank you. We have a question here about the psychiatric evaluation. I guess getting at the sense that when patients are depressed, they cannot commit suicide legally. But what I guess the question is, by no means should we aid those people who are depressed to commit suicide. So why should we aid those who are not depressed to do so? So that's open to anybody in the panel talking about the role of depression, the end of life. We talked about some of the issues. There's data referenced about depression and cancer at the end of life. Does anybody want to speak to that?
I can just clarify that conventional suicide is legal in every state of the country. And that is because if a person attempts suicide and fails, the last thing you'd want to do is then, you know, press charges against that person and have them go to jail, right? That would be awful. That's exactly the wrong solution. And that's why suicide is legal. And yet, as a society, we've taken a very strong position that we don't want suicide, right? So every state has these active suicide prevention networks. I'll just say briefly that Judge Richard Posner, who was of the Seventh Circuit Court in Chicago for almost 40 years, actually, he just stepped down in 2017. He was a really staunch advocate for the legalization of MAID, or assisted suicide. And he actually explicitly wrote about how conventional suicide is unseemly. It's an embarrassment for families. There's a problem of how to dispose of the body. And he specifically wrote that the solution then is to have physicians write prescriptions to legalize suicide. So this is Judge Richard Posner, who's an advocate, but he recognized and wrote very clearly that the whole point of bringing in the medical profession was to sanitize the process of suicide. And I know there's been a lot of, you know, back and forth on the language, but this is from advocates of legalization that it does in effect sanitize the process. And I don't want that to be lost in this conversation.
Thank you. Did you want to add anything, David, or?
Well, I don't think it's sanitized in any way. Again, this is just another medical care option for people who are dying and are going to be dead within a very short period of time. And these are those people who take the medications are generally speaking, again, well-educated, they have healthcare insurance, they're receiving the best quality end-of-life care, and they make this decision and actually take the medications usually within days or weeks of the time that they would have died anyways, at a time when they still have the capacity to do so. And some actually, for some, the window actually closes. They have the medication, they are planning to take it, then they lose the ability for either capacity reasons or physical reasons. So we're not talking about, again, your typical suicide, which is committed by a person who could continue to live but chooses not to and does have mental health issues. I would agree that there may be some cases which are missed with regard to those who have clinical depression to the extent that they don't have decision-making capacity. But of course, it's understandable for people who are dying that they would be somewhat depressed because of their impending deaths, that they would feel very saddened. And so that's not an unusual state of mind for a person who is close to death. But that does not mean that they don't have the capacity to make rational decisions for themselves, whether, again, we would agree with those decisions or not. And sometimes we wouldn't agree with some of those decisions. But nevertheless, on occasion, there will be people, just as people who ask to have a ventilator withdrawn, for whom death will result, they too may have serious depression, which maybe is missed, although we should do everything to address any symptoms or any quality of life issues to hopefully ensure that people aren't going to prematurely end their lives, whether it's because of withdrawal of life-sustaining treatment or because of medical aid in dying.
Thank you. Does anybody want to add something? Sorry. There was a question about, I guess, when we think about 6 months or less to live, where does adult failure to thrive fall in the criteria for MAID? Dr. Muller, do you want to take that one on?
I don't, because I don't know the answer to that question. I think I remember the person who asked it describing that it's no longer a hospice diagnosis. Right? Is that the language of the?
Yeah. So it's someone who can't endure VSED. They're, I guess, no longer in hospice. Maybe they don't have the terminal diagnosis, but it's a failure to thrive. I don't know if that gives clarity to the question.
Yeah, I don't think the failure to thrive falls within the confines of the intent of the medical aid in dying law. And I guess I'm also not sure in terms of the specific question that someone, quote, can't tolerate VSED, because in situations where someone voluntarily stops eating and drinking, part of the role of the physician, if they've gotten to the point where all of the conversations have happened and it's an appropriate decision, part of the physician's responsibility is to make sure that the process is tolerable with medications that either are comfort meds, sedation. So at least in my experience, when patients, and it doesn't happen often, obviously, but when patients have chosen to voluntarily stop eating and drinking, we make sure that they have medications at home that their families or caregivers can administer so that it's a comfortable process that doesn't really involve any distress at all.
Thank you. And looking at the time now, this is such a robust conversation, but I just wanted to turn it over, give Allison an opportunity to give her closing remarks for today's presentation.
Hi, everyone. I'm Allison Squires. I'm the chair of the DIAM nursing section and also an associate professor at New York University in the College of Nursing and the Division of General Internal Medicine. I've been asked to reflect on this robust discussion. How one does that, given the range of topics that were covered, is a challenge, but I decided I'd talk about this from several hats that I wear. One is as a health services researcher. I'm struck that, there wasn't more said about how insurance companies are rationing care and how they decide who gets coverage for what treatments actually contributes to patients moving toward medical aid in dying. And the question is why aren't we talking more about insurance reform in terms of why this is consistent when care is denied for profit, essentially? The other aspect is this notion of the primary care relationship. This has been mythologized very widely, but is really something that has been declining. The average length of time a person spends with their primary care physician these days is about 8 years. And so can you really get to know someone well over 8 years if you only see them once a year? Or, if you have 7 minutes to spend with them? And so the notion of this 40-year primary care relationship, that doesn't really happen anymore. And so really getting that relationship about who's making the decision from a primary care provider perspective is a very different story. And so in terms of, do you really know the patient? That's a good question. Also, as a researcher, I was struck as the conversations were going on about how the research evidence actually lacks patient voices on this. There are no qualitative studies that I could find in PubMed, which is a free searchable database run by the US government that holds all of the evidence known for everything. And there are several thousand articles on medical aid in dying, assisted suicide, et cetera. And, but when I looked for studies that were qualitative in nature that would represent patient voices, there were none. The only qualitative studies that were done were focused on clinicians. So I think the evidence around this maybe is lacking the patient voice. Why we should hear from people who are choosing that. It would be an IRB nightmare from a researcher perspective, but it is a major gap in the evidence. And I think there needs to be more research in that area. And finally, in terms of wearing the hat of, I was also reflecting on two stories that I know of. One is my friends Karen and Mike, and Mike had Parkinson's, and he and Karen had long conversations early at the onset of his disease about what would happen at the, when it got to the point where he couldn't function anymore. And how would he signal her? And he said, well, what they decided is that he would stop eating. And sure enough, he stopped eating, and 2 weeks later, he passed. And I also come to this perspective as someone who has a parent with a degenerative neurological condition that was diagnosed, that is incredibly rare, was diagnosed too late. For those of you who are clinicians, it's spinocerebellar ataxia type 8. And it is also, so it's kind of like a slow moving ALS for the non-clinicians in the room. And this has been happening over 10 years. My father's been in hospice for 2 years and has been under hospice care for 2 years, but at home, and has almost 24-hour care at this point in time. And we couldn't have these conversations about what his wishes would be. He can no longer speak. He's not had executive function for several years. So even if he had made those decisions, if we had known what his wishes were back then, we would not even be able to ask him about those wishes now. And he is alive. He has lasted as long as he has because of good quality nursing care. They're not in a state where medical aid in dying is legal. They're also in a state that doesn't have really great quality healthcare. The number of times we have had to switch physicians or nurses or whomever until we finally settled on quality care has been a challenge. And in COVID, this whole situation has been exacerbated with the local nursing home being, shall we say, unwilling to do testing because they don't want to find out if they have a problem or not. So the complexities of these issues are very real as we look and we see and we think about the examples of people that we know. I think the thing that strikes me most is that people want choices, and who are we to deny people choices, whatever that choice may be? And, you know, but they should be informed choices. You know, and on another point with the researcher hat back on, there's also a shortage of people who have the competence to do depression screenings. There's a national shortage of mental health care providers. So yes, I totally think everybody should have a depression screening or a mental health evaluation of some sort if they're making this decision, but it's going to be discriminatory in that way as well because of unequal access to mental health services and the lack of mental health care providers and who can complete that level of screening. Psychiatrists may want to maintain their jurisdiction over mental health screenings, but there's too few of them to actually meet the demand that might be out there in the market. And so, you know, if we allow psychiatric mental health nurse practitioners or even nurses at the primary care level to do depression screenings, then, you know, that could actually meet the demand that would be out there for mental health on multiple levels, but in particular for these situations. So I close out not really having any answers, sort of remaining again neutral on this issue overall, but very much mindful that respecting people's choices should always be at the heart of whatever we're doing when we're working with patients. Thank you.
Thank you so much, Allison. Thank you. That was a lovely summary. And I want to thank everyone who's spoken today, David Leven, Assemblymember Reyes, Dr. Muller, Dr. Dugdale, and Mary Ellen Trisgallo. Thank you so much for sharing your perspectives and opinions on this issue. Just also a note, this has been recorded and it will be available upon request for those who would like to view this again. I also think that all of our panelists today are also open to future conversation. You can reach out to them by contacting New York Academy of Medicine, perhaps to get their contact information. But thank you for your fantastic questions today. Thank you for your time. And thank you for discussing this really important issue with us today. Any last comments from Elena or New York Academy of Medicine to share? Okay, fantastic. Thank you so much.
Thank you, Ayana.
Have a great evening.
Bye-bye.
Thank you all.
Thank you,
Thanks,
everyone.
everyone. Bye-bye.
Thanks, everyone. Be well, stay safe. Bye.